Pass that there. Well, we drew a crowd this afternoon, yeah? Everybody online?
All right, everybody. Hi, good afternoon. It is 3:56, 3:36. And it is Thursday afternoon. It's
Yeah.
been one heck of a week and it continues to be the most interesting week. May 18th, 2023, and I'd like to bring this meeting of the Committee of the Whole to order. Clerk, please call, the roll. Before we begin the roll call, as we're still all getting used to the change in the Open Meetings
Madam
Act.
Chair,
Yes.
before you do that, I think you have to establish a quorum before you can go to the next step.
I think that's correct.
He's correct. All right.
Yeah.
So I
That
think
was
we need to,
So
thank
you
you.
would call the roll.
Call the roll of the individuals who are currently in attendance. Then we will bring in those individuals who have sent us a notification, which you will have to approve by 3/4 of the people who are in the room to see if there is a quorum, that may be admitted.
I believe, Madam Chair, Shepro,
Is that accurate?
you will have to make up the quorum because I only see 6 board members in the room. Okay. But at this moment, quorum being 7. Sorry, quorum being, no, actually, we don't have a quorum in the room.
We do not.
We have a majority of a quorum with you, but we don't have 13.
So we can make, if that is the case, we can discuss.
We're not voting on anything today.
We're not voting
No.
anything anyway.
It's not officially a meeting, but
We need 7 more.
So it's a bunch of us just getting together and chatting.
Well,
yeah.
Oh,
Yeah, but
since
you still have to keep a record because it's a majority, yeah, but it's a majority of a quorum.
Mr. Iqbal is in the room. Here's Mr. Iqbal. Thank you, Mr. Iqbal.
Now we need 6 more.
Wait, what?
How many of them would qualify online?
1, 2,
Oh,
4,
discuss, it's not a meeting.
4.
10,
Yes,
it's not a
4
meeting, we
online?
can't
That
discuss.
we can admit in.
no, because it's been noticed.
All right, let's do a count. We've got 1, 2, 3, 4, 5, 6, 7, and there's 4 that have legitimate reasons that we can vote in.
Well, you don't have to vote them in because you don't have a quorum in the first place.
can't vote them in. We won't be able to. vote.
So they can, like anybody else, I guess they can listen in. But it's not a meeting because you don't have a quorum in the room.
So we can have a discussion since we have got people here.
Yes, I believe you can have a discussion
All right, so
because
And if we can
notice of the
explain to our
meeting-
guests,
notice of the meeting has been given.
correct,
So the public is aware and could be here and listen.
correct.
and for our guests, this is our first meeting post the
Pandemic.
electronic
Yeah.
pandemic falling off rule. And so we're kind of bumbling through it a little bit. So.
It-
You still need you need a roll call to establish that there isn't a quorum.
Right, quorum has to be in the.
Lovely. So I have one more question. We'll call roll with all those board members who are currently in attendance. Then I can admit by vote, by 3/4 of the vote here, no,
You don't get to that.
because we don't.
But they're
have-
here, I mean, they're online and I suppose
Can participate.
you can elect to let
Have them
them
listen.
listen. Yes.
All right, so, fine. Mr. Tarver, Ms. Silva, Mr. Young, Mr. Doherty, Ms. Gums, Ms. Molina, Mr. Tepe, and Ms. Allen, you will be admitted in so that you may listen and participate, but this is simply a discussion. So could you please call the roll of the people who are here?
In here,
in
okay.
Here.
Berman, Iqbal,
Present.
In person.
Juby,
Should be present in person.
Caius,
Guys present
In person.
and in person.
Linder,
Linder here, present in the room.
Roth,
Roth here in the room.
In the flag.
Surges,
Here in the room.
Pirog.
Here in the room.
We do not have an in-person quorum.
Okay, we do not have a in-person quorum, but we will go forward with a discussion. So I assume,
You may also ask the sergeant at arms to compel the attendance of the absent members, but that's never been done.
um,
Who's the sergeant at arms?
The sheriff. Well, guess you can't compel him to bring anybody here.
he's not going to go fetch them.
They're not gonna call.
As far as protocol, sir, Mr. Shepherd, please, do we still proceed with the Pledge of Allegiance? We have no need for public comment because we are simply a
This is
discussion.
not a meeting.
This is
that's-
not a meeting.
That's correct.
Here's Mr. Tarver.
Mr. Tarver is in the room.
Yeah,
Meeting now.
Okay.
no.
No, not yet.
13.
You still, yeah, you need 13. Or 12 plus the chair.
Oh, this year.
So I would, without needing public comment and without needing Pledge of Allegiance, since this is a discussion, I'd like to turn this meeting over to Mr. Surges, where he can
Non-meeting
introduce,
meeting is turned over to you.
introduce his guests.
For our discussion this afternoon, we have from the Assured Partners team, Mike Baker, D, and inside joke. They, Assured Partners, as we discussed at the last meeting, is our consultant that handles our healthcare. They are part of our team. They, when we, for refreshment, when we left the IPBC, the consortium, and went on our own, it was very important to us, being a self-managed account, that we didn't try and do this on our own, that we brought in outside professionals that were accustomed to doing this. We spent time with Mike and his team to craft, build, procure the tools and databases that we felt we needed to be able to manage this on our own. It has been extremely successful. The iterations that we've gone through have been to not only pull from the collective, establish with, at that time, the carrier we had, which was Blue Cross Blue Shield, get comfortable with setting a reserve account to which we reserved so much that it was identified that we should bring our reserves down. We stretched our policy term from a 12-month term to an 18-month term to better align with open enrollment. And this is the first opportunity that we've had in probably that 5-year journey to actually openly solicit bids for the insurance and on what we would finally call a level playing field, so that we can compare what we had with our prior carrier to what we might have with the new carrier. And I think from the discussions we had the first time, Mike, you weren't here, Luke was here, but the discussion was very much about disruption and the notion that while we've come miles, the reality is, even if we stayed with our exact same plan and carrier, there would be a disruption in terms of the pharmaceutical side, because that that changes about every 6 months. And there's no guarantees that what a person may have had today, the formulary would be the same at this next 6-month cycle. So, and I only say that, and I'm repetitious on that, to build to the point where I don't want anybody thinking, listen, we can set it and forget it and just stay with our current carrier and leave it alone. Everybody's going to be happy. That's a fallacy. Somebody's going to be upset. And we're going to give a call to D, and D is going to try and explain, well, we changed formularies. Why? Because that's just the way the contracts are. What we can control is the disruption between the doctors that are available and the specific coverages within the contract. Am I being fair and somewhat accurate? Okay. And so today, last week or 2 weeks ago, we met with Blue Cross Blue Shield, who kind of gave us where they're at. Mike has an update on things that have happened, transpired since then. And United Healthcare is here to say there's an alternative that we'd like you guys to be informed of. Ask questions, try and put together a package that we might say, if we're serious about making a change, you've now heard from them, What is it that we might need to tweak or build in? Remember, we're a self-funded, self-managed. They help pick up the claims and then click in after a first certain stop loss. So this isn't just, here's what we can do, have a great day. There's a little bit of negotiation saying we might want a little bit of something else, or maybe that's not so important to us. But we need a foundation to start from, and that platform is here. So, Mike, I probably stumbled more than you would on that, but feel free.
Good to see everyone. Blair, if you could put the one slide of the financials up, I just want to do a recap and then I'll turn it over to United Healthcare. So there's a
Use
lot
that
of,
a little.
yeah, that'd be great. There's a lot of numbers up there. I'm not going to bore you with all the numbers. I just want to high level recap some high differentials between Blue Cross and United Healthcare. Couple of things from the initial renewal that Blue Cross provided the county. Don, and our team negotiated improved financial discounts of $580,000 if you renew. And Blue Cross also reduced their cap from the current cap of, on your worst case scenario, for 842,000. So high level, that's perfect. We don't need the last column, Blair, so that's perfect right there. So if you look at line 12, that's your county's expected cost. So currently we expect the county to spend just under $18 million. So that's the $17,811,000. And the purple is your revised renewal from Blue Cross. So expected with Blue Cross would go to $18,374,000. That's a 3% increase. The expected with United Healthcare Choice Plus, and that's the PPO network. The HMOs would go to United's Navigate network. The expected claims under United Healthcare is $15,803,000. So that's expected. However, since you're self-funded, you could pay more, you could pay less. We ask for guarantees. So the county does have what's called aggregate stop loss protection, provides you a worst case scenario for all claims underneath your stop loss level of $205,000 on any one person. So if we look at line, right under line 12 in italics, you have contract maximum liability. So our current in the light blue, your current maximum is $21,584,000. Blue Cross has reduced that for the 2024 plan year to 20 million in the purple, 20,743,000. And with the United Healthcare option, your maximum is 17,842,000. Now, the way the maximum with United Healthcare works is you would have to renew with them and then they would reimburse you. There's a cost share program that they're going to explain in their part of the discussion, that if you run over 5% of expected, they share in the amount over that 50-50 until you hit the 17,842. But you get a check or a credit back in month 16. So you could spend $20 million and then you would be reimbursed your money in month 16. So I'll let United Healthcare explain how that works.
Mike, would that not be indifferent than when it was with IPBC?
So with IPBC, you paid like a fully insured. So they billed the county the same rate. You put that in. They had reserves on set aside for the county that they made you wait 18 months to get reimbursed. And that's, you got a check for roughly 1.1 million 18 months later. So it's different than that. This isn't the reserves. This is saying for the next 12 months.
Okay.
For 2024, United Healthcare is saying we will guarantee that you will not spend more than 17,842,000. Now, I will preface that's based on, you can't see it, but it's 900. I think it's 919 employees. So it's based on your head counts. It changes each month. So if you added 100 employees, your maximum is going to go up. If you drop 100 employees, that maximum is going to go down. So it's based on the head counts that are in the details to who you insure. Any questions on the financials?
questions? No.
Just for clarification, are we talking initially about a 1-year contract or 2-year?
Right, so both United and Blue Cross on your administration costs, they have guaranteed your rate for 3 years. Claims, since you're self-funded, you're going to pay your claims. The guarantee is a 1-year guarantee, and then insurance gets renegotiated every year on that piece. Good question. And this is your discussion, right? It's not a meeting, but this is your discussion. So ask any questions of United Healthcare, how they will, process claims, their way of controlling costs. So I'm going to turn it over to the United Healthcare team.
Great. Thanks for that, Mike. Good afternoon, Kane County Committee of the Whole. I first want to say thank you very much for allowing United Healthcare to come on out here today and discuss with you the power of partnership and a little bit of the capabilities that United Healthcare has to offer today. As Mike had mentioned, this is a meeting for you to learn more about United Healthcare and our solutions and what we can bring to the table. So any questions that may come up during our presentation, we'd love for you to ask questions, ask for details, insights, examples, anything like that, so that you can feel more educated about our solutions and what we have to discuss today. So really quickly, in terms of introductions, my name is Robert Niemczyk. I am a senior account executive in the key account segment. So I partner closely with Mike, Dee, and Don from the Assured Partners team to making sure we're putting together the right strategies and solutions in place for Kane County. And then my teammates, Mike Teleski, Vice President of Sales. We've got Scott Banky, Strategic Account Executive in the key account segment. And then we also have Ken Rose, who is our Optum RX Area Vice President in the mid-market segment. And then your Medical Director, Dr. Nicole Brady. In order to be as efficient as possible, we decided we'd keep the team to a minimum here today. So really quickly, in terms of the agenda and what we want to discuss with you is just quickly go over the proposal in terms of what solutions we have to offer, a little bit about who we are as an organization. We will touch base on the network, the member experience, pharmacy, and then at the end of the day, why choose and move forward with United Healthcare. So really quickly, in terms of your proposal highlights, within the proposal we've put together, there is an implementation credit of $100,000, a wellness credit of $50,000, and that is on an annual basis. So you would receive that credit every single year. A Health Action Council growth credit of $30,000. That also is on an annual basis. And we will get into the specifics of what the Health Action Council is as a group purchasing coalition. Along with that, we will discuss the Advocate for Me Elite Clinical Model. This is an enhanced customer service model to what you have today. So it's an additional level of customer service. Also, we've got the Behavioral Health Solutions package built in. This is offering guidance for you and your families regarding access to care and making sure you understand the different avenues and resources you have under that. With our Pre-Check My Script pharmacy integration program, this is making the health system work better and smarter for you, and we're doing so in real time. And we'll get into the specifics on how that looks. And then finally, at the end of the day, when we're going through all these different programs, this is how we are showing our savings from claims costs and how we are processing and paying your claims. As Mike had mentioned, we've put together a guarantee on our ag risk share, and we will specifically outline for you what that looks like, and so you have a better understanding of that. So unless you have any questions, I can go ahead and hand things over to Mike Teleski to give you a little more insights about who we are.
Great. Good afternoon, everyone. And thanks again for having us here today. We really appreciate the time. So I just wanted to really quickly at a high level run through United Healthcare and United Health Group, our parent organization, for those that might not be familiar, excuse me, with who we are. United Health Group, Fortune 5 organization, largest national insurer in the United States, but really created and made up of two distinct but complementary organizations. United Healthcare, which is the brand most people are familiar with, the benefit side of our organization, but also Optum, which is our services side. And many of the innovations and services that the team will talk about today come from the Optum side. And they're very distinct but complementary business units. And there's 3 foundational competencies across both organizations. That's going to be clinical insights that we'll talk through. It's technology and innovation and our investments in that space. And then data and information. We're incredibly data driven. And this is all founded on our united culture across both organizations. It starts with integrity, compassion for those that we're honored to serve, relationships such as a relationship with our consultant partners, assured partners, and our clients and customers, and innovation. I'll talk a little bit more about our investment in innovations. And of course, it all leads to performance, which is long-term trend management as a self-funded county. You know, your investments into the health and wellness and engagement and experience of your employees and their family members, being able to share in that experience and see ultimately long-term positive trend performance in the running of your plan. So to go a little bit deeper into the numbers of United Health Group, we are honored to serve 151 million people. It is the largest national proprietary network. Rob will talk a little bit more detail about network numbers with over 1.5 million physicians and 6,300 hospitals. I'll talk a little bit more about the investment in technology and innovation, but over $5 billion a year go back into making the healthcare system work better for everyone and helping people to live healthier lives. We'll talk a little bit more about that. We have over 400,000 employees worldwide now under United Health Group, and over 142,000 of those are clinicians, doctors and nurses that are all working to help members live healthier lives and improve the healthcare system. So locally here in Illinois, incredibly proud of what we're able to do and our presence here in Illinois, even though we're the largest nationally, a really strong presence here in Illinois. We have 1.5 million members now here in Illinois, 8,000 employees across 14 different offices within the state of Illinois. And just a couple of quick stats on our diversity, equity, and inclusion investments in the state of Illinois. Some of our partners on the left side that we've been privileged to donate to and support, the Dream Builders Foundation, a grant to the University of Chicago to help them through the COVID pandemic, Every Mom of Chicago, and a couple local partners on the right side. But the impact of our investment in the state is reflected here on the slide, specifically 178 jobs directly supported or sustained in 2022 in the diversity, equity, and inclusion space. Almost 16 million in wages due to diversity investments in 2022 within the state of Illinois, and the impact of over $45 million in small and certified diverse Illinois-based businesses within the state of Illinois. So just wanted to share those numbers with you. We're incredibly proud of those. I mentioned I go a little bit deeper on innovation and investments, that $5.1 billion that's invested annually. Scott and Rob will talk a little bit more about some of the outcomes and how that really helps to engage, improve the member experience, and take cost out of the system, which I know is incredibly important as a self-funded county. We are proud to be most admired for 13 years running in Fortune magazine and 14 consecutive years as ranked #1 in innovation through Fortune magazine. We like to talk a lot about total cost of care. So traditionally, the gold standard back in the past with evaluating carriers was always on discounts. And that's a unit cost approach. And that worked for many, many years and was really good at predicting cost when comparing carriers. What we'll talk a lot about today is everything that goes beyond cost and discounts. And that's a table stake. We compete very well against Blue Cross in the local marketplace on true unit cost discounts. But to really take costs out of the system, improve the member experience, it's everything that flows sort of under the surface. If you think of discounts on the top of the surface with an iceberg, that'll be network design and what we're doing with our network contracts and value-based contracts. Rob will talk a little bit more about that. It's clinical and pharmacy integration. Scott will touch on that because our integration and partnership with OptumRx and the pharmacy side, and wellness rewards and affordability initiatives, things that we're doing along payment integrity, things that we're doing in the physician's office as they're prescribing that results in lower cost for your members and lower cost for you as the plan sponsor as redirection to lower cost alternatives because we're putting information in the hands of prescribing physicians on their electronic medical record. We'll talk a little bit more about that when we get into the pharmacy section. And all of that leads to what Rob had touched on and what Mike had touched on from Assured Partners was our aggregate performance share. This is unique in the industry. We are willing on a self-funded group to take on risk on the stop loss. So we are confident in our ability to manage cost and look at how the claims run. We've worked very closely with our partners at Assured Partners to come up with a claims estimation and working with our underwriting team and actuaries to start sharing risk, as Mike had mentioned, as you get above 105% in how your claims run. Most traditional stop loss contracts don't start taking on that risk till 125%. We will start sharing 50-50 at 105%. And so it really reduces your maximum liability to that 115% with us as your partners side by side all the way through, because we are now invested in managing those claims for the long term. I know there was a question about renewals. This program can be renewed at the second year as well. So when we look at the stop loss renewal in year 2, we can keep it involved. That would be part of what Scott would bring to the table, is introducing the aggregate risk share in the second year as well, in addition to the multi-year fixed cost guarantees. And I went through a lot very quickly there. Any questions on anything that I covered?
You're moving at a good speed.
Okay, wonderful. Thank you very much. Thank you. With that, I will turn it back over to Rob to talk a little bit more about network.
Thanks, Mike. I'll try and maintain that pace here. So as Mike had mentioned, one of those important cost of care factors that we really focus on to make sure we are managing those claims dollars is through our network solutions. And here you'll take a look at the different range of network choices that are available to you. So when Mike Baker was running through the numbers in the initial slide there, he was focused on our Choice Plus network. This is our largest PPO proprietary network, the largest coast to coast nationwide. So that is the PPO network that we would be leading with for the county and your members. And then from a HMO perspective, we would be leading with the HMO Navigate network. So this is the network where there's a premium, a PCP that is assigned, and members utilize their primary care physician in order to seek services through a referral with their PCP. Now, below that, underneath the national network, we also have local networks, and these are different strategies we have in place for long term, so that this isn't viewed as just a 1 or 2 year relationship, but 3, 4, 5 years down the road, and what we have set up and available to you, such as the core network, which is more of a local value-based network that we sometimes see different organizations move and utilize, going from Choice Plus down to core. Now, one program that we have built into the networks is called our Premium Designation Program. And what this is we are writing value-based contracts with every provider within our network. And we're focusing on quality, and we're focusing on cost-efficient care. So what that means is that every single provider we contract with, we're making sure they're evaluated using over 220 specialty-specific performance measures. So we are not simply contracting providers just to get them in network, just so that we can drive up the number of physicians in the network. We're making sure that we are evaluating them, and should they meet those specified criteria, they earn a designation of 2 Blue Hearts, 1 based on their cost efficiency and 2 based on their quality. So when you have a member that is going online, looking to seek services with a provider, they will go on myuhc.com, type in the search network there, zip code 60134, and providers that are in network will not pop up specifically based on location, but on premium designation. And the reason we have it set that way is because if you've got a member from the county looking to seek services, if we're driving and tiering those members to go seek services with a premium care provider, you'll see that there's a 10% lower cost of care with those providers than with non-premium designated providers. You see a 23% fewer average redo procedures utilizing those same premium care providers. So again, this is one of the ways that we are helping to manage and maintain the county's claims dollars, is by helping drive members into those premium designated providers. Now, when we're talking about change, there's always disruption. Yes, sir.
Mike, in the plan that we have HMO and PPO. When we're discussing Choice Plus, is that the same scenario?
Choice Plus is going to be mirror the PPO plan. So they will match the PPO plan, and then the Navigate network would be for your 2 HMOs. So one thing that would be different is there wouldn't be two different HMO networks. It would be one HMO network with United. So if there's any plan variances, you may still have two. There's some slight copay differences. You would have two HMO plans based on copays, but not tied to network.
Okay. So this is equivalent to the PPO. So I'm sorry to interrupt.
No, no, not at all. Absolutely. We welcome questions. So,
Could I ask a question about the slide prior to this one?
yes, sir.
Can you go back one slide? The premium care physicians performing knee replacements had 23% fewer average redo procedures. Is that an overall statistic or is this 23% is, I see it's just knee replacements.
Correct. Yeah. So for that specific procedure,
Yeah.
there's a 23% difference in cost if you're having that procedure done with a doctor that is premium designated versus a doctor that is not.
Okay.
Great question.
Is that nationwide or statewide?
That is nationwide.
Oh, yeah.
We can provide client level reporting on that if you'd like to see those statistics. So. Okay. So quickly in terms of disruption, we ran a disruption analysis with the Assured Partners team. And based on your utilization with your members in the PPO network today, should they switch over to the Choice Plus PPO network, you'd see over a 99% match. So disruption at that level would be very minimal. And again, you see the top providers and the provider names on the right-hand side. Now, this is for more of the value-based network core. And then for Navigate, this is the HMO network that we were discussing as well. So again, over 97% match for your members utilizing in-network provider. So again, a great disruption.
Does that include, thank you, does that include the doctors as well within that network? Not
Yes.
just the hospitals, but also the doctors who work within those hospital networks?
That's correct.
It includes that we did we got a full file on the PPO from Blue Cross. So on the Choice Plus, that is doctors, hospitals, we scrub it and look at that. On the HMO, Blue Cross will give us hospitals and they will give us the physician group. So what's the one? It's slipping my mind. We have in Aurora, there's a big physician, Dreyer. So Dreyer Clinic is a big HMO group. They won't tell us which Dreyer provider your member signed up with. So United and Navigate has Dreyer. Blue Cross won't release that data on which provider they're seeing.
Thank you.
Any other questions on the disruption at all? All right. As I had mentioned earlier, the Health Action Council, this is a group purchasing coalition that's really based on resource dedication, better outcomes, and unique analytics. So essentially, at no cost, we are able to provide an enhanced dedicated customer service program for your members, as well as enhanced clinical team. So with over 450,000 members with United Healthcare under the Health Action Council, you receive that enhanced level of Advocate for Me elite customer service handled specifically from a team outside of Duluth, Minnesota, as well as a clinical team outside of Buffalo, New York. So based on the members' ability to have this enhanced level of clinical programs, customer service, this leads to a 1.9% average trend over the past 11 years, which is significantly lower than what we typically see for groups year over year. And in addition, you are receiving a $33 per employee per year annual credit. So you're actually making money and receiving additional revenue based on being a member within the Health Action Council. Again, you see a loyalty renewal credit. So it's $15 and then $20. And by year 3, it's $25 per employee per year. In addition to that, there's several educational events that are offered to your members every single year in order to help continue to drive their consumerism within healthcare. And this comes at an annual cost of $2.75 per employee per year. So again, financial incentives, enhanced advocacy, and improved outcomes for being members within the Health Action Council. All right, I will now hand it over to Scott to get into the member experience.
Thank you, Rob, and thanks again for your time this afternoon. We talked a lot about the financials, the network. Two things that I wanted to touch on is the member experience. So what does this all mean for your members? How does United Healthcare work with them? And then also look at a pharmacy plan as well. So we talked about the investment in technology, and we're going to outline that in what we go through here, how we're really helping be a consumer-centric organization, again, working with your employees and their dependents. So one of the first things I want to hit on is really helping to deliver a better experience. And one of the ways we do that is through the integration of the medical and the pharmacy plans. By doing that, you can see here what we've got is called point of care assist. And what this really works on is making sure that doctors have all the information right at the tip of their hands. They're in the office. They're able to see all the details surrounding the individual instead of waiting or having things come on the back end. Maybe it's something like a prior authorization. Historically, it might have been some paperwork. They have to contact the insurance company. In that aspect, there might be some delay in care. We're able to do that all right within the doctor's office. There's some examples that you see up there on the screen: the gaps in care, patient eligibility, prior authorization, looking at things such as ambulatory surgical center referrals, maybe lab selection. So if somebody's in the office, the doctor needs to refer them to a certain place for whatever test or service that they need. The doctor has that information all in the palm of their hand on their electronic medical records. United Healthcare is integrated with that. We'll talk a little bit more about pre-check my script from a pharmacy perspective, but again, having that information, what the employee's pharmacy plan, when we're looking at things such as the different tier of drugs, which can be different out-of-pocket costs, and there may be prior authorizations associated with that as well. The doctors have all that information right there. Yep.
Mike, help me translate this again. Some of the struggles that we've heard, you had mentioned possibly in the HMO that you associate with a specific doctor group. And if you went to the north end and you associated with this doctor group, unfortunately, their specialist might be in Bolingbrook. And so you say, well, how do I get to the guy that's at Delnor? Well, you have to switch to their Northwestern medical group in order to get those people. In what we're seeing here and what you had just mentioned a moment ago, does that situation still exist with UHC, with the doctor groups? And is that just for the HMO or does that go for the PPO as well?
Yeah, when we're looking at the PPO, obviously it's what we call an open access plan. So you really have there's no primary care physician, there's no group in regards to that you have to sign up for. So you can get referred within the network without having, again, to switch medical groups. Maybe I'm within,
Minimal disruption that we're
correct.
seeing.
Yep.
What about the HMO?
Yeah. Yeah. So that is a PCP relationship. So you would have to go, based on the network of the referral there.
Okay. So not dissimilar, still a pain in the ass.
So I'd maybe think of it a little bit more flexible than the environment today, because today, as I understand it, you have to stay within that practice. I think your example was one practice, they've committed to that practice, they can't see the specialist in the same organization in another practice. Under our program, it is the individual PCP, and that PCP can refer anywhere within our network to any specialist.
Oh, interesting.
So yeah, so that PCP wants, now obviously most systems want to keep, the care within their system. It allows them to have a clinically integrated network. So they might not be very happy about referring outside of their network, but they are able to, and by just doing an electronic referral as a PCP. So they're not required. It's one of the benefits of not being a heavily capitated arrangement. That's why they keep them within the practice, because they're paid on a capitated basis. We've removed that and allows some more flexibility. So I think members under the HMO see a little bit more flexibility with their PCPs being able to refer within the entire network versus within a sole office.
And that capitation concept was difficult for me to grasp for quite some time. But I understand what you're saying. Michael, you were going to stand up, or were you okay? Got it. Thank you so much for the answer there.
No problem.
And again, truly, for my colleagues, I'm looking at this from the phone calls that would, if you did make a switch, what are the phone calls coming in? Because I think that we should do the very best that we can to prejudge those calls and in anticipation, ask those questions so that we can make a formal decision here in the not too distant future. So I hope they're not dumb questions, but
No, perfect. Yeah, I appreciate the questions. The other area we want to focus on as well when we're talking about member experience is really behavioral health. Obviously, coming out of the pandemic, we're seeing a lot more focus on that. We're seeing it across our book of business. Want to make sure that individuals have the right resources that they need for that. There's a lot of information up on the screen here for you. I think the main point we really want to make is that United Healthcare, through our behavioral health solutions, has something for everyone. We want to meet the individual where they're at, what their needs are. If you look along the grid in the middle, you can see the left is kind of what we'll call low severity. Going to the right is looking at high severity. On the left, starting at education, we then look at things such as self-care. So we have our Able To program, which is essentially an app, a virtual program for individuals. It's really a self-directed program that help individuals deal with whatever, maybe it's some anxiety, some stress that they're going through. There's self-guided exercises that they can walk through to manage that. As you move along, we also have some telephonic support and coaching. There's our Talkspace program, which allows individuals to kind of text as opposed to maybe waiting to see a provider within the office. They're able to get immediate assistance through text. We then move along over to in-person, looking at different pharmacy options as well. And then as we look at high severity on the right-hand side, really that facility-based care. So the main point really want to get across here is that we want to meet the individual where they're at based on their needs and their preference. And we have something for everybody that allows them to deal with whatever situation may be going on with them. Any questions here?
I do, regarding the mental health, is that age restricted? So if a parent has a child who's 14 years old and needs help, will they have access to that, or will they have to go through their parent to get them access? And secondly, is this 24/7 available if you are feeling stressful at 3:30 in the morning?
Yeah, to the first question, if they're 14, obviously the parent would be able to set that care up for them, depending on the individual. When you're looking at things, maybe an individual is over 18, but may still be on the plan, there's different things such as, HIPAA rights that we'd have to deal with. There's a consent form that could be signed there, but, generally the parent's setting that information up.
Okay. And 24/7?
Yes, when we're looking at some of the apps like self-care, virtual visits, those type of things, when you're looking at in-person care and the facility-based care, obviously that's going to depend on the provider, but there is help 24/7 as well. And we'll talk a little bit about that on the next slide when we look at virtual visits.
I have one more question. We have a lot of parents whose children are still on their healthcare plan. They may be going off to university, or they may be relocating their very first job. And they can stay on the plan. Is this plan able to guide multi-state?
Yes, yeah, our plans are national, so our networks are national, that individuals that when they are going off to school, in that situation that you outlined there, they would have access.
So
to
the care is
providers.
seamless.
Correct. Yep.
Continuation of care.
And I think one of the things that we're hitting on as well, when we're talking about, maybe it's the app, self-guided, obviously they can take care of that, but then also virtual visits are available as well.
And I'm also talking about physical health. And
Yes.
that's
Yeah.
seamless as
Yeah, they
well.
can access our network nationally.
Thank you.
And kind of segueing into that, looking at the virtual visits, we do have the 24/7 virtual visits. And as we, again, came out of the pandemic, we saw a lot more utilization and traction, through the virtual visits, individuals meeting, whether it's on your phone or your iPad, your desktop computer, individuals are able to connect with a medical professional. And there's different range of conditions that are available. I can say from personal experience, so my daughter away at school was able to get her strep throat diagnosed, get medications right there without having to leave her dorm room. So there's great convenience for that as well. And depending on how we set up the benefit plan there, you can see some of the costs there that can range from $0 to $49, really dependent on how we set up the benefit plan. But again, we've got several different providers. You'll see on the right-hand side, Optum, part of United Health Group, is our main provider that we utilize, but there's also the option to look at Teladoc, Doctor on Demand, Amwell, and virtual care as well. So again, just another way we're taking a look holistically at the individual and providing different resources for them to get the care that they need.
I have a question.
Sure.
For the number, the 800 number of people call, are those a US based answering or is it international?
Referencing the customer service or?
Yes.
Yeah, so that's US based through the Rob had mentioned the Health Action Council. We actually have a dedicated team
Okay.
of individuals that are answering those calls. So definitely US based for those.
Okay. Thank you.
I have
Right.
one more question.
Sure.
As we're going through this. Does your plan provide a full range of women's health care?
Yes, we do offer women's health care. I don't know if maybe elaborate a little bit more on that
I-
question.
The full range. From family planning to menopause and beyond.
Yeah, I mean, part of that's going to be dependent on the plan as a self-funded plan, how you want to, set that up from what's covered and what's not covered, but we are able to offer the full range of options for that.
Thank you.
Yep, go ahead.
Madam Chair, so as a self-funded plan, we will, if you were to change, United Healthcare would match the exclusions and what's covered under the PPO and under the HMO. So they would build it that way. They have different ways of reviewing claims for physical therapy, for chiropractic. They may have different programs for prior authorization, but whatever's covered under the plan today for Kane County and all the programs would be matched with the United Healthcare plan.
Okay, thank you.
Right. Another way that we're offering assistance to members, and this is a great program, one that we're all very proud of, is what we call our special needs initiatives. So individuals, whether it be them or someone in the family that maybe have, some complex condition, cystic fibrosis, for example, we actually assign a dedicated advocate that specializes in helping them with care. So you can see some of the savings along the bottom section there, but I think the biggest thing is really the stress that we're able to help that individual with, or that entire family. And this advocate is not only just assigned for that individual with that complex medical condition or special need, it's assigned for the whole family. So obviously there's enough that they may have to deal with as they go through in managing that condition. These advocates are able to assist them with maybe community resources, all their benefits, claims, finding providers, those type of things as well. So just wanted to make sure that you're aware that we had that available to your members. All right, we talked a little bit about, you mentioned the 800 number. So, and Rob had talked about our advocate for me. Main point I want to make here is we have, a real holistic view at the individual. When somebody's calling in, we have advocates that are able to assist them. If it's someone just calling in regards to a benefit question, they may not have a lot of claims. They may not have utilized a lot of services. We have benefit specialists that can help them out as well. But then we also have all the way up to nurse advocates that are able to assist individuals who may have more complex conditions. I mean, you can see on that circle there, and we'll talk about this quite a bit, is really just a holistic approach that we take to helping our members. And maybe that's, wellness, community resources, pharmacy, condition management, that whole experience. You hear a lot about social determinants of health as well. We also have resources for that. So really just want to make sure that, that our advocates can assist them. They have the full picture. They're able to help those individuals in whatever they may be dealing with. Yes.
So what does the changeover look like for, let's say, somebody with a complex, we have a organ exchange, somebody who's a diabetic and is on a treatment, somebody whose child is in some sort of special care. What's the disruption look like in terms of, gosh, now you can't get to your drug? Gosh, your doctor's got you on this program, oh, but if you're switching to UHC, now you've got to re-credential or step therapy or re-administer what, do you get to just, hey, if I'm on this, I get to stay on this? Or do you have to work what's that look like?
There's a couple different ways that we can help approach that, specifically talking about the pharmacy, there's different information that we can get from the prior carrier in regards to prior authorizations. Maybe it's mail order prescriptions as well that still have refills. We're also, if we are able to obtain it, get clinical reports. So individuals that have those conditions and maybe seeking service currently, that if they can provide that information to us, we're able to get that into our system and we're able to start helping them from day one. We'll also do education surrounding, hey, these programs are available, get them, connected.
This is not a concern or a big deal.
No,
I'm a sheriff's officer. I've been told I need the new knee. I was waiting until I had some vacation time where I could actually dedicate. I didn't want to do it during the winter. Do you have to submit everything to say, do I really need a new knee? Is it that type of disruption we're going to see? Or is that, Cliff, don't worry about that. That's not a big deal.
there may be some cases, depending on, where they're at in the treatment and the process. Like I said, we can bring over your prior authorization files that we can get loaded into the system already. So it's going to depend on the individual situation. We try to minimize that as much as possible for individuals. Like I said, through communication.
We're talking 1,300 employees, in excess of that. And we're not naive to think it's going to go smooth as could be. But by and large, is it, you need to re-up on everything?
Like I said, it's going to be dependent on what information we can get. We're trying to minimize that. So if we can get that data in and get that into our system, then we're able to take that and run with it and make it as smooth a transition as possible for them.
And does that happen, Mike, carrier to carrier, or is it specific doctor to carrier? So I'm the patient, I'm the employee. I have to reach back to my doctor and say, hey, all of that stuff that was already in your system, it didn't carry over, even though you're Northwestern, it didn't go from Blue Cross over to UHC.
Right. So the pharmacy is probably the easiest portion to get into the United Healthcare system if you change, because we can get files from Prime Therapeutics that gets loaded, that gets put over, right? Then, you can get the approvals or look at pending surgeries. It depends on the file Blue Cross would send to United. There is some areas that there is going to be a little bit of disruption, lost in communication, whatever, the doctors would have to resubmit and go through that process. But if you choose to change from, if you make your decision this summer, when you say go, there's a whole team from Assured Partners, United Healthcare, working with Jamie and the HR team to start moving all of that stuff over.
Okay. And if I'm missing questions here, guys, please. But I mean, I think that we're looking at dynamic cost differentials here. And so as a board, we might lend ourselves to go with something that's financially favorable. But with 1,300 employees, does a couple $1 million really matter? And so the minimum, I hate that word disruption, but the minimum aggravation, we're only a 4-person department in the HR. I mean, so 5 people. So how can we handle all that? And so I'm just thinking through the aggravation versus the savings. And that's what I'm trying to, and so that's where my question, Mo, you had a question as well?
Yeah, I have,
Use your microphone.
Oh, okay. Better?
Yes.
I have several questions, and first of all, I want to thank all of you to come here and, make a presentation. It's very kind of you. My first question is, you have gave us several numbers regarding the coverage that you provide across the nation and internationally. For Illinois, what percentage of population do you cover?
So we have 1.5 million members in the state of Illinois.
1.5 million?
In Illinois, yes.
A question was asked, Mr. Sturgis asked a question about the knee replacement. That may be a little bit not that common, but consider a more common scenario called Humira. There are people who are on Humira and they give that shot. How hard it is and how easy it is for them to keep on that getting that Humira shot.
Yeah, I mean, generally, it would just be, going through our pharmacy, we'd get them set up. It's a specialty medication, so we have our Optum RX pharmacy team that works with that, making sure that they're continuing. It'd be their doctor kind of submitting that script back to United Healthcare after the transition.
So
Oh, are you asking, so like if a person's been on Humira for 3 years, they're not going to lose that prescription?
No, correct. Yeah, they would not lose that prescription.
that's my question.
I think that's what you're asking, right?
Yeah.
Yeah.
You mentioned benefit specialist, but I'm familiar with United program long time ago, and you had a program called early risk resolution or early resolutions program, in which you call a number and there would be an advocate. You tell him that your claim has been denied, and he would look at it and she would look at it and resolve the matter, right there. Do you have that program intact? I haven't heard that word, early resolution program.
Yeah, I think it's just termed our Advocate for Me program. So I'm not sure, historically what it, from the name perspective, but through the Advocate for Me, through our customer service, through the model that we have, the individuals are able to address that. So I think it's just maybe a different name when you're looking at that, but there's also some added benefits through the Advocate for Me program and what they're able to assist with.
Okay. The term is for 1 year, as I understand, but this is a very short term. What is the renewal process? Is there a guaranteed premium that you will guarantee that you will continue us on next year and after, or every year it will be reevaluated, or any procedure?
How do we know this isn't like the introductory one? Save 2 million this year, but you pay 4 million next year.
Yeah.
So as a self-funded county, as Mike had mentioned earlier, your claims are your claims. We've agreed with the aggregate risk share proposal to take on risk with you on the claims. The fees, the fixed costs on the fees are guaranteed for 3 years. So those are disclosed, those are locked down. Your stop loss has to go through a renewal process, much like a fully insured piece, because that is an insured risk that we have. So if we do our job and we manage the claims well and we keep your folks, healthy, that renewal will be, negotiated with the Assured Partners team.
Things you can control, it's a 3-year lock.
Correct. And the things that we necessarily
Are really
can't
ours.
are and shared risk, to be honest, because if we miss on that aggregate risk share, we're on the hook for that. And that's the bigger piece. I mean, your fixed costs are the very, very small part of your annual benefits cost. The vast majority is claims.
Mo,
That's
you-
the variable piece.
You get
That's
that?
claims.
A little bit, I get it. I mean, it's the same thing.
Because they don't play our claims. We're responsible for claims up to a
Okay.
threshold.
Exactly,
Yeah,
yeah.
so if we hit that maximum amount every time, we'd like it to be less.
But I'm looking at their risk point of view. You have reviewed our risk, or, our
Correct.
whatever you call it, burden. Based on that, what risk do you see you are taking that you are not sure you are taking?
Well, so I think our expected claims were 2 million lower than what is expected under the current carrier. So that's the risk we're taking on. Our confidence that all of the programs that we've talked about, the integration, closing gaps in care, engaging with your employees and their family members, will deliver that savings. The pharmacy program and integration across all the programs is key for this. So that's the risk we're taking, because if we're wrong and your claims are 40 million, we're on the hook for everything over that 17 million on the max. We have to own that, and we're ensuring that through the stop loss premium. So that's the risk we're taking, but we're both in this for 1 year. You can leave next year. If we don't do our job and we don't deliver on everything we promised today, it'd be very uncomfortable to move in a year, but that's always an option to go out. And of course, our partners at Assured Partners know how to negotiate on things and look at things and look at the predicted risk. And they have some fantastic tools that work in concert with ours to predict what we think. I do tell you, we do not expect to miss that guarantee. So we wouldn't be in business very long if we were missing these guarantees. So we're confident enough in these to roll out this program where we're sharing on claims risk for self-funded clients like yourself.
Good one.
So you're expecting lower claims. Years ago, employers used to brag about how well their insurance took care of their employees. Today, we brag about how many claims we're able to deny. Are you saving us $2 million in claims by denying more claims or by finding some other cost efficiencies?
Yeah, I really appreciate that question and thank you for that. A denied claim is a deferred claim. It will come back. I mean, right? And it's an engaged member, a healthy member, a member that makes the right choices. We actually refer to it as a health activation index. Members that make the right choice for every percentage of time when they're presented with a choice and option in the healthcare system, when they make the right choice, for every increase in this health activation index that we track with our data and analytics, it reduces claims by 0.5 percentage point. So not by denying site of care, redirection, the right choice, the right place at the right time, all of those things flow into that. Claim denials are a thing of the past, flat out. They're not good for anybody and they're not good for long-term trend. They didn't work in the past. So when we show claims reduction, it's coming from all the programs we talked about, but not from denials. It could be a site of care redirection. It's getting people closing a gap in care, working in concert with their physician and with our clinicians. If there's something that comes up that we know, through that advocate program, the dashboard, which we're also sharing with providers on that point of care assist dashboard that Scott talked about, working with them to close those gaps in care. If somebody's not being adherent to their medication, we want to make sure we fix that. And even our nurses can help with that on social determinants of health. And our partnership with the Health Action Council, which is a nonprofit, they have a clinician that helps close gaps in care on social determinants of health. And with your population all centrally located around Kane County, would be a great opportunity for them to engage on where we see gaps locally in Kane County. It could be a lack of urgent care or immediate care versus emergency care, things of that nature. It could be affordable housing. That's what they do and bring to the table with the partnership with Health Action Council.
I thank you. My, gentlemen, how much longer do you think? We have a couple of people that have a deadline. You think you need 5 minutes?
We have like 3 slides. We can on pharmacy.
Okay, and I know that Madam Chair is another engagement. If you need to go,
Yes, please.
we would be happy to continue.
That would be fine. That would be, I don't want to rush you, but
Yeah,
We
and
have
and this
another
way
meeting
we
I have
have
to
what
travel
we
to.
need, but please do not feel that today has been a trying day that I'm sure Mike will share with you for this board and a very unusual day. And so, but I want you to feel free and then I don't think we want to be past here
So-
past 5.
so formally, I will take, like to turn this over to Mr. Surges, who will continue to lead this. Thank you all so very much. It was very interesting.
Thank you. So I do have 2 things on your comments on, is this a 1-year deal and is it gonna, how do they guarantee and the expected claims being lower? So we don't believe in 1-year moves. 2 things that are different with United Healthcare and the pricing. And we went back and that's why we got the guarantee. We pushed United Healthcare to give a guarantee. So on your HMO, the county currently pays Blue Cross Blue Shield $4.7 million in HMO capitation payments. It's back on that financial summary. So what that is when a member signs up and you have 2/3 of your members in the Blue Cross HMOs, they sign up, they pick Dryer. Dryer is getting paid every month because that member chose Dryer. Whether they go to Dryer or not, they're getting
Regardless
paid.
if they're seen, Dryer's people still get paid.
Sorry, it's 2.7. Don just corrected me. So 2.7 million is capitation. So United Healthcare contract is only paying HMO providers if they are seen. Of that 2.7 million, Blue Cross breaks it out in the renewal. About 15% of that is bonus payments if the doctors keep costs within a certain realm, but that's Blue Cross's secret black box. But so 2.7 million, there is, quick math, about $400,000 in bonus payments to providers. So of the 2.7 million, one of the questions is how much of that is actual claims utilization by Kane County members? How much of that is cushion? So somewhere between probably 400,000 bonus payments. I don't know how the others made up. So that's one of the differences. We also gave them an RX file. So in the RX file, it's line by line claims for the last 12 months of every RX that was paid. So in your RX file, it's called an NCD number. Pharmacy is one of the craziest things to get your hands around and understand how the pricing works. And you can have a different price for the same drug at CVS versus Walgreens under your same contract with Prime. And you can have contracts with Prime with a different company. They get a different contract. So under Blue Cross's HMO, we're not allowed to pull out Prime Therapeutics. You have to keep Prime Therapeutics. So they have a quasi monopoly on your HMO RX. Can we carve out the RX with United Healthcare? We could. So we gave them the file. The other area of a lot of savings from what they gave us, now they're putting a guarantee, right? So if they're doing a 1-year buying of business, they're going to pay you on the guarantee, but their RX cost is about $1 million to $1.5 million off the top of my head, lower than what the Blue Cross numbers are on the ingredient cost. So those are some of those differences of where they're getting the savings. They looked at every drug that was taken by your members and the pricing, and they have different contracts on their RX that they can price. And we review that for our clients. If clients of your size, we review the RX every 12 to 18 months to keep the RX companies honest. So
3 slides.
3 slides. And we have some pharmacy slides, really, I think the whole message again is just making sure that, we're seeing the holistic view of the individual. We're helping them. We talked about some of the, the claims and the denials and how we're getting that savings. It's through helping individuals live healthier lives. It's identifying those gaps in care and, closing them, making sure that we're acting on that and making the best healthier decisions.
Sorry.
Yeah, the microphone.
Sorry about that. So
Perfect. Thanks with that, Scott. So I know a lot of information and absolute fantastic questions. We really appreciate that. I could tell that the committee is very engaged. So again, why United Healthcare? Based on the programs that we've discussed here today, access to our largest national PPO network, as well as the HMO Navigate network here locally, a dedicated account management team with the Advocate Elite customer service team located in Duluth, Minnesota. So all the 1-800 numbers that the members would be calling in specifically here nationally. Clinical coordination within our doctors and making sure that there's a minimal disruption moving from one carrier to another based on the coordination programs and models that we have in place. Making sure that the claims are repriced and paid accurately the first time, making sure that there's as little issue with that for your end users and members at the end of the day. And all those programs, again, bringing them together under that aggregate risk guarantee that we've been talking about, making sure that we're putting our money where our mouth is in terms of the fixed costs, the expected claims, and showing resolution and savings based on your engaged members utilizing the programs. So again, we thank the committee for allowing us to come present here today. And if there's any other questions, we'd be happy to address them now.
Jamie, is there anything, let's face it, you're going to be the front line here. So anything that you have that we've missed, anything that you feel is important that we haven't addressed? Mr. Lindner, I think your question was really, thank you so much for that. How do you make the difference up? Is it, or are we just being overcharged by the other guys? It's yin and yang.
I think, as it's been stated, there's, change always includes some differences and that's inevitable no matter what we do. I just want to remind everyone that our advisors, assured partners, they're independent and they advise us using their knowledge of the market and the insurance system. And we put a lot of stock in their opinion. They don't take a commission. They are paid by us directly just to advise us in our interests. So as we go through this process, we do rely heavily on them for their opinion and their analysis. They've been deeply involved since we moved out of the collective and are very familiar with all of the details of our benefit plans and exactly how our employees are using our benefit plans. So they're really our best
Have you
best
had
resource.
any pushback communication at all from any of our union affiliates saying, hey, by the way,
We
this is
have-
our feeling, or
We have not put out any official communication since the
Okay.
decision really hasn't been made. So what we're really looking is for the board to digest this information and give us further direction on if we want to continue to pursue a change. And then among that would be an opportunity to formally communicate the intent to consider a change out to the unions, which we haven't done. But we've spoken of this several times in public meetings and I have not yet heard anything.
so in past years, we've presented 4 different carriers. Mike, this time we're only presenting 2. Is that because you whittled them down for us? And just in an effort to not overcomplicate this? Is that are these the 2?
Correct. We went to, so there's 4 main players in Chicagoland. Aetna, they did provide disruption analysis, RX reprice and a full proposal. They weren't competitive. And Cigna, same. Cigna's had a lot of leadership changes locally. So they did the RX reprice, the disruption, and they provided proposals. They weren't competitive. So it was between Blue Cross and United.
Okay, fair enough. Any questions at all?
This is Alan. I have a question.
Hey, Deb.
Hi. Is there any way prior to our making a decision for an employee to find out if we made a change, if his or her preferred doctors, psychiatrists, the people they're currently dealing with, is there any way that they can call someone and find out if those people would still be included in the United Healthcare plan?
Yes, they can, myuhc.com can be searched for provider searches without having to register or being a member. So folks can go on today if they would like and do a provider search. It would be the Choice Plus network or the Navigate network. And we'll work with Assured Partners to make sure we get something out in writing with a link to that. But folks could search today. They don't have to be a member to go onto the website, the portal and search, just go on as a guest.
And Jamie, would Christine be able to help with that? Is she the person on staff or no?
We could certainly direct them to the website if they'd like to look up and see if their physician is, so we can, even if, we want to end up, if we do decide to pursue this further, we would definitely share that information with all employees.
Deb, does that answer your question?
Absolutely. I think that if we're trying to give some sense of security to our people, that would be a way to do it.
Agreed. Anybody else?
Just quickly add, if they do find that someone is not contracted, our network team is local. We have a process for that, a quick form, a nomination, and we can reach out to that provider and talk to them about becoming a network. I think it would be pretty rare looking at the disruption reports that Rob had shared, but we do have a process for that and would welcome those nominations if somebody's provider was not in network.
Super. We all want to get out of here. So Mike, my question is, what's the next step? We have a deadline, Jamie, of August, July. You mean like in 2 months, July, like 60 days, July?
Yeah, so next steps would be if the board has further questions, if unions have further questions, please get them to Jamie. We can get them answered. We can set up additional smaller meetings with either Blue Cross or United if you want further information. So the process, my understanding, it obviously goes through HSC. So depending on how when you're looking at timing, your next HSC meeting is June 14th. So we can get the information, and if there's any meetings you need before that, or if you want to use that meeting to, go through final information, we could be ready for the June 14th meeting.
I think your real question, Shep, is what
Microphone.
What action item deadlines are there?
And that's what I said. I think that August is our deadline.
You need to make a decision in the July Human Services because the August board meeting would need to have a final decision in order for us to have sufficient time to work with
Right.
Smart Ben to actually have this ready for open enrollment and all of our communications in place.
Okay, so we'll plan on seeing you at the next HSC meeting for a recap and give direction by then. Gentlemen, is that fair? Committee of the whole, is that fair?
Yeah.
Okay, we'll accept a motion.
Move, no, we can't really vote because.
Right. Well, we have to motion to adjourn the meeting. Okay, then. Thanks for stopping by, everyone. It's good to see you.
Thank you, folks.
There you go. Thank you.
Thank you, everyone.